especially for the adjunct physicians. So can you see my slide? No?
We are seeing the presenter mode now.
Okay.
Yeah, we can see it now. Thank you.
Okay, the first, the part is goofy. So the Elobixibat is a world first ideal virus transporter inhibitor to increase the virus flow into the colon. So you know the virus act of physiological dual action. Dual action means one is chronic watery secretory, which soft the stool, and the other action is to stimulate the colonic motility to improve the peristalsis of the colon. So, you know, in Japan, the aging population is a problem. So in Japan and Western countries, so the critical importance for the treatment of constipation is, this slide shows that constipation cause lower long-time survival rate. As you can see here, the observation period 15 years, the patient without constipation and the patient with constipation. Constipation group shows 23% lower the overall survival compared to the without constipation groups. So suggesting that the constipation is, the lower the survival rate. But I'm not sure the other countries, but in Japan, this is a serious problem in the clinical settings. So in treating constipation, the physician is interesting only in the presence or absence of defecation. That is very simple. But, that is not enough for the patient, especially not enough for getting the good satisfaction. So we need to go one step further to increase treatment satisfaction. But what we can do in the clinical settings, the goal of the treatment is to normalize stool form. That is a Bristol stool form type 4 through therapy. For example, increasing the laxative dose or decrease the laxative dose to achieve the type 4 is a good is the best way, I think so. Not whether stool defecated or not. So this slide shows normal stool form type 4 has the highest QOL. You can see here the normal stool group has significantly better QOL score than hard and watery stool groups. With the type 4 group has the best QOL scores. So higher probability of achieving complete spontaneous bowel movement in case of type 4 too is shown here. As you can see here, if the type 4 stool is into the rectum at the defecation, you can see here the diameter of the rectum and the anal canal differ greatly. So abdominal pressure must be applied during defecation. But type 4 stool deforms like lovable and is easy defecated. It's a normal defecation. But in a middle illustration, this cartoon shows a hard stool do not deform. So they require the strong straining. It increases the blood pressure, and it takes a long time and fall apart when the defecation. We call it divided defecation. And right panel, if the foam stool became watery, in case of watery stools, the watery, the watery stool pass easily through the anal canal. So everybody thinks this is no problem, but this is a serious problem for the patient. You know that during the defecation, when the rectum contract, that half of the stool flow back into the sigmoid column. Half of them defecated, but half of them flash back to the sigmoid column. And after 10 or 20 minutes, stool return to the rectum, and the patient feels a strong, incomplete evacuation. So that's why the patient go to restroom several times, sometimes 10 or more times. So it's very, very hard for the patient, especially in cold season. So in a Japanese clinical settings, so the Professor Miwa reported that the hard stool remained in osmotic or stimulant laxative. And you can see here that the patient prescribed osmotic laxative. Half of them shows hard stool, and the patient taking a stimulant laxative, half of them shows hard stool. That is a very serious problem. Only 8 or 11% shows type 4 normal stool. So treatment with a new drug improves the stool shape is necessary, which is good for the patient satisfaction. In terms of stimulant laxative, as you know, the effect of long-term continuous use of stimulant laxative is cause a serious problem. So that's why in a European guideline or American guideline or Japanese guideline recommended that in case of using the stimulant laxative, on demand or short time period usage is strongly recommended. If the patient take a regular use of stimulant laxative, so for example, the Senna had tachyphylaxis character, so the dosage increased and finally decreased autonomic peristaltic ability of the colon, resulting in the colonic inertia. So this slide shows a patient perform a colectomy. She is a 31 years old female and taking 68 tablet of 10 milligram sinusoid tablet. So the huge amount of laxative abuser. So it is important to use stimulant laxative only on an as needed basis, and to avoid using them for a long time. So this is recommended by the Japanese guideline as well as by the American guideline. So last year, revised Japanese guideline for chronic constipation has been published. The first one is published 2017, and the second one is published in last year. As you can see here, the Japanese guideline recommended to the first line used is osmotic laxative such as magnesium oxide and PEG or lactose. And if the osmotic laxative is inappropriate, so the second line is recommended secretable or either virus transporter inhibitor Elobixibat. So as you can see here, the stimulant laxative is recommended as needed rescue or short-term therapy. The Japanese guideline for the chronic constipation last year showed that Elobixibat is newly listed on the flowchart and is highly appreciated. You know, the IBAT inhibitor are effective for chronic constipation, and their administration is recommended strong and evidence level A, and Delphi agree percentage is 100%. So the what is the Elobixibat is a virus transporter. So the first of all, what are the viruses? So as you can see here, the main role of virus is digestion of lipid and the absorption of lipid in the small intestine. Viruses that are not absorbed reach the colon. Just only 5% reach the colon. And the viruses that enter the colon are known to promote bowel movement. The virus act two physiological effects. One is the promotion of bowel movement. The other is the promotion of the colonic secretion, water secretion in the colon, which is mediated by the virus receptor TGR5, only exists on the colon. Interestingly, recent investigation revealed that the virus stimulates the secretion of incretin, such as GLP-1, suggesting that the increase in virus in the colon improves the glucose tolerance. So this slide shows what the virus is necessary, especially for the constipation patient. As you can see here, the concentration of primary virus in the feces show that the constipation patient shows a lower concentration of virus compared to that of control. And you can see here the patient with diarrhea shows a higher concentration of bile acid. The 50% of IBSD shows a higher concentration of diarrhea, higher concentration of virus. So, the considering that the patient with constipation shows a lower dose of virus in the patients. So the mode of action of GUFIS, Elobixibat, is inhibit the ileal bile acid transporter about 10%, leading the bile acid increase in the colon, and in the colon, bile acid stimulate the colonic secretion and the colonic motility. So in the Japanese phase 3 clinical trial shows that the Elobixibat shows a change of frequency of small bowel movement 5.4 compared to the 1.73 for the placebo group. That you mean the patient get the everyday bowel movement and especially the spontaneous bowel movement. The Elobixibat 10 milligram group shows about 3.39 in comparison to the 0.62 in a placebo group. That is very excellent data. And in addition to the bowel movement, the median time to the first SPM was just 40.1 hours. And you can see here, compared to the placebo group, so the first bowel movement is just 5.1 hours. And lastly, in the clinical 3 trial, we get the excellent data showing here that in a total period, 1 year total period of taking Elobixibat 10 milligram, you can see here that most of the period shows stool form type 4. It is very good for the patient. And, the proportion of, the Elobixibat is available 5 milligram, 10 milligram, and 50 milligram, 3 dosage. The proportion of 3 dose administration in a year is shown here. The first patient taking 10 milligram Elobixibat and allowed them to take 5, 10, and 50 milligram according to their condition. So after 1 year period, the 33% taking 15 milligram and 33% taking 10 milligram and 33 patient 5 milligram. So it's the dose increase on the dose reduction is very important to get satisfaction for the patient. In terms of the adverse event, the adverse event is there are 2 adverse events: diarrhea and abdominal pain. And these side effect is occurred in a very early initial phase of starting the drugs. There is a very interesting paper from Yoshinobu 2 years ago. So the Elobixibat groups lower the hemoglobin A1C and the LDL cholesterol in patients with type 2 diabetes. As you can see here, the Elobixibat administration of Elobixibat lower the hemoglobin A1C, which is caused by the increasing GLP-1. And the bile acid is made from cholesterol. So the increasing bile acid into the colon suggests decrease LDL cholesterol. As you can see here, taking Elobixibat for 12 weeks, serum LDL cholesterol getting down significantly. And this slide shows the discontinuation of stimulant laxative or saline laxative after GUPS treatment. As shown here, the 55.4% patients were able to end to take stimulant laxative with a year after GUPS treatment. This is the last slide. Today's summary. Stool consistency is important for patient QL. Traditional laxative may not contribute to chronic constipation. Treatment by the aspect of the stool consistency. Fecal bile acid concentration was significantly lower in constipation than that in healthy control. Elobixibat is the world's first IBAT inhibitor to increase bile acid flow into the colon. Bile acid provides physiological dual action. GUPS has additional metabolic effects such as improvement of LDL cholesterol, diabetes. GUFIS can be considered as the first option as dual action with recovery of rectal sensation. Thank you for your attention.
Thank you, Professor Nakajima, for that very insightful presentation on a very, very interesting novel drug. So now I would like to encourage everyone to please send in your questions quickly. So I think, Professor Nakajima, that at least one good thing about Elobixibat is its name. GUFIS is certainly easier to remember than some of the other drugs that we have.
I think the GUFIS name of you mentioned the name of GUFIS. So GUFIS means good pieces. So it's easy to.
yes, certainly. Yeah. Okay. So while we're waiting for questions, maybe I could just ask Professor Solano, what is this perception gap between physicians and patients like? Physicians are more interested in the frequency of bowel movements, and they define narrowly as twice a week, or at the most 3 times a week, or once in 3 days. Whereas I think for many patients, it's actually the completeness of defecation. What do you think of that?
Yeah, good question, Kugan. I think our education in medical school, and of course, perhaps our first impression about defecation when we are growing up, are very important, factors that influence our definition as physicians when we look at constipation. And we really just what our slides are showing, most of us are really concerned just on the number of bowel movements that our patients do in 1 week or maybe in 1 day, while patients have a more encompassing definition of defecation and therefore later on constipation. A lot of them talk about the sensation of completeness of evacuation, the patients who are worried about straining, and then there's this concept about that we see all the time in our clinics that when they are unable to move their bowels, they think that they are depositing toxic elements in their bowel, and so they need to defecate, and that increases their anxiety, that increases their urgency to have bowel movements every day, and thus this disconnect between their definition of constipation and our definition of constipation. And so that when the Rome 4 criteria has at least defined these definitions to us, the doctors, then we will hopefully in the future and now be able to make those considerations when we ask the patients about constipation and put them all together so that both you and the patients and us can understand very well, and we have our expectations and outcomes defined and in uniform, both the physician and the patient.
Okay, so now we have a question for Professor Nakajima, which I'll read out from Dr. Ruben Chavez. He asks, how effective is Elobixibat in patients with surgically removed gallbladder?
Surgical?
Yes, this one.
Pardon? Oh yeah. How effective is Elobixibat in patients with surgical removed gallbladder? In a Japanese experience, so the patient who received removed gallbladders, so the effect of Elobixibat is very good. So I don't understand. Firstly, I don't understand why the effect is same. So the patient removed gallbladders, the secretion of bile acid or bile juice is periodic. Not continuous secreted. after after the breakfast, after the lunch, after the supper. So the increased bile secretion is observed. That's why the Elobixibat is effective for those who are removing gallbladders.
We
Thank
have
you.
another question now from Dr. Anuchit Suksamai. Can you show the question on the screen? So he asks, in the patient with chronic constipation, which failed to conventional laxative drug, do you have an experience for using combination of Elobixibat with prucalopride or linaclotide? And is this an appropriate prescription? That means combining two different classes of laxatives.
Yeah, unfortunately in Japan, so we cannot use prucalopride. However, we can use lactose, magnesium oxide, and PEG. So in a critical situation, so many doctors use combination with Elobixibat with osmotic laxative, which is a good combination. If the patient taking Elobixibat, it is not enough for the treatment. In this case, the physician add the osmotic laxative. It's a good combination. But the combination with Elobixibat and the stimulant laxative is no good because the effect is very strong. Thank you for your question.
Okay, so the next question is from Dr. Hastomo Prabowo, who asks, does this medicine, Elobixibat, affect patients with colitis or irritable bowel syndrome, IBS?
The patient with IBS, so the IBS-C. So there are few papers demonstrating that the Elobixibat is effective for the constipation dominant IBS, but no paper for the colitis. So maybe the patient with colitis is we don't have a data. Thank you for your question.
Okay, let's move on to the next question, which is from Dr. Desmond Y. Can we show up the question on the screen? Dr. Y is asking, any experience to use Gufis with other laxatives? So that has been partially answered. Can Gufis be used as on a required basis? That means you use it on demand rather than on a continual basis. And what is the longest safety follow-up data? So maybe you answer the second question.
The number one is already answered.
Yes. So the second question, can it be
can Gufis be used as required? What do you mean, PR?
It means on as needed basis, not on a daily basis, but whenever the patient feels constipated to use it.
Yeah, I don't have much data, enough data about as needed. So I think I don't have enough experiments. In Japan, so the label shows that take a drug just before breakfast, lunch, or dinner.
Yeah.
That's it. Thank you. And
I think. Sorry, maybe I'll interject here. I think the question misses the point that we are talking about patients with chronic constipation, not on occasional constipation.
That's right.
So that's why I think Gufis should be used on a regular basis rather than on demand.
It's. I think it's okay, but we don't have enough experience. So
I think in among patients who have very good response to goofies, and we have this type of reaction where on the second day of intake they have already good bowel movements. And usually in the Philippines, because most of the medications are bought by the patient, what I prescribe to them is, yeah, you can take, because you have a very good outcome with the patient with bowel movement. So I tell them maybe you can take the drug for at least 2 weeks, and if you have very good bowel movements on the days that you are taking goofies, increase your fluid intake with the lifestyle modifications as well. I advise them to taper off their treatments on a whenever necessary basis. And I have a few patients who have responded to that very well. Some patients, of course, will also get relief after taking the medication, and because they are the ones buying their medications, at a certain point in their stay at home where they don't see you, they also try to quit the medication. And so, in this type of real world situations, yes, you will have some patients who will have also good relief with as needed type of basis for taking the medications.
Okay, let's have. So Professor Nakajima, maybe you could now tell us about the longest safety data follow-up that you have. I mean, your study shows 52 weeks. Do you have?
Yes, so we have after-market survey for 3 years. So we are now preparing a paper submission. So based on the 3-year experience, we have no serious side effect, and the efficacy is very nice. And in Japan, we have 7 years experience in a clinical settings. So it's a good reputation now. Thank you.
Yeah. Professor Nakajima, one question. My patient was very happy because even in the earlier publications with Elobixibat, that advantage on LDL cholesterol has been already documented in a small number of patients. And so he was very, very happy that his diabetes might have some improvement, and cholesterol and SBA1C might improve. So this particular data that you are showing in the first part of your studies, are these also being documented in the long-term patients who are administered the drug?
Yeah, we don't have a data, but it's a good question. So we are now gathering the data about for long term, and with the statin user or without statin user. So it's very interesting data. So thank you very much.
Okay, next question, please. Yeah, so somebody's asking about the safety of Elobixibat use in for patients with liver cirrhosis.
So you know the label of Elobixibat recommended not to use this drug for the severe liver function, but you know the compensated cirrhosis. I think compensated cirrhosis is okay for use Elobixibat because reduction of bile acid is good for the liver. Thank you very much.
And then I think at the end we have one more question. One more down. Oh, wait, do you have any experience? Okay. Okay, so do you have any tips for reducing the use of laxatives in patients who have been taking them for a long time? I presume the question will be referring to the use of stimulant laxatives predominantly as a concern, as you have raised up, Professor Nakajima.
Yes, we usually add on the Elobixibat to the stimulant laxative for the initial stage, and then the patient reduce the stimulant laxative as much as they can. So in 1 year or 2 years, so the stimulant laxative is reduced. So that's my experience. Add-on is the best way.
Actually, we have one, I think, one more important question. So we will try to address this, and then maybe after that we can wind up the session since we are actually a bit beyond time. So this question asks, will Elobixibat cause intestinal ulcers because of the accumulation of bile acids? I guess they're referring to the, particularly to the colon. Any risk for the colon? Because as you know, bile acids can irritate the colon, and that's in one way in which it causes diarrhea in patients who have bile acid malabsorption. But what about patients who have constipation? Do you foresee any risk of it causing intestinal ulcers or colonic ulcers?
The Elobixibat affect only the colon, and the patient with constipation shows a low concentration of bile acid in the colon compared to the healthy patient. So the Elobixibat just 10% increase in the bile acid in the colon. That is nearly normal concentration. That is a physiological concentration. I don't think it's cause chronic injury or ulcers. And from our 7 years experience, we don't have these serious cases in Japanese situations. Thank you for your question.
Okay, we have one last question, which I think is particularly of interest because it is a very common practice, particularly with primary care physicians, to use to prescribe lactulose, or even the patient get it over the counter, and sometimes patients may use it for a long time. So, do we foresee? We open up to both Professor Solano and Nakajima. Have you encountered any side effects that might come with this prolonged use, and also any special patients need to be cautious about the use of lactulose?
Yeah, I think lactulose, especially in those who are or those of us who are looking at liver as well, we give lactulose for patients who have developed portosystemic encephalopathy, and sometimes we give them for some time, for long times. And so far, the major side effects that we see in these patients is, of course, bloating, and if they're not very careful with the dosing, is diarrhea. So these patients should be reminded about electrolyte imbalance, and clearly, of course, also dysbiosis. And so if you have dysbiosis happening in these patients, maybe you get more bloatedness, you get more abdominal discomfort, and these are some of the side effects that might happen in patients who are taking a long-term lactulose.
Professor Nakajima?
Yes, in Japan, so lactulose is not commonly used, but the physician does not want to use lactulose because of most of the patient complain bloating. So that is a serious problem for the Japanese patients. Thank you.
I think to me that's the same problem with fiber. That's why I'm not totally in favor of this push to increase dietary fiber because it causes a lot of bloating. And I think bloating is one of the biggest thing that affects the quality of life of patients with chronic constipation. Now, although I said we want to try and finish up, but there is a particularly important question which I think brings up a good, unique feature for Elobixibat, which is asking what type of patients may benefit more with Elobixibat. For example, the elderly and those with Parkinson's or diabetes and kidney disease. Do you think that Elobixibat has a special position for use in these kind of patients?
Yeah, that's a good question. But the Elobixibat is the good effect for the diabetes, Parkinson's disease, and kidney disease because the Elobixibat has a dual action. So the increase chronic motility and secrete the water in the colon. So that is very strong effect, especially even for the Parkinson disease or kidney disease and the elderly patient, because in the elderly patient, the lower motility of colon is reported. So the before using the stimulant laxative, Elobixibat is a good choice for these patients. Thank you.
Yeah, I think I just want to add that there is a paper which maybe I can't remember if you presented from Professor Manabe, which showed that Elobixibat can improve the rectal sensation to create an urge to have a defecation. So I think from that perspective, it will be particularly suited for patients with Parkinson's and elderly, where I think sometimes it's a loss of this sensory perception for bowel movement.
I think there are several publications already of a few series of patients exactly looking at all these diseases that are here in the slide. Which used Elobixibat. It's safe, of course. Efficacy is also acceptable.
Okay, I think with that question, we can now call this meeting to a close. But before that, want to ask for your feedback on the session. I think we've had a very interesting program where a very novel drug has been introduced for a very common condition. But I think the most important first step is that we as physicians must better appreciate how much our patients with constipation suffer with their constipation and the impact on quality of life, and to take them seriously and want to treat constipation seriously rather than just asking them to go back and take more fiber and drink more water. Okay, so I think with that we close this session, and then I'd like to ask you to help us complete this webinar survey. So thank you for attending this event.
Thank you very much.